It's really fortunate that over the last few years, we've had a significant increase in the number of therapies available for neuroendocrine tumor patients. Nonetheless, there still are a number of unmet needs. The reality is that for patients with high-grade neuroendocrine tumors, they still have generally rapidly progressive disease, and while there is some interest in applying immune therapies and using chemotherapy, there still is a rapid rate of progression and low survival for those patients. In terms of the well and moderately differentiated neuroendocrine tumors, inevitably the tumor does progress and there's a need to use additional therapies. In low and intermediate grade neuroendocrine tumors, while we typically start with somatostatin analogs, there's certainly room for newer delivery systems for these somatostatin analogs. Also, there's a need for additional therapies for patients with breakthrough symptoms. While we do have drugs to control carcinoid syndrome diarrhea, for example, in the form of short-acting octreotide or in the form of telotrestat, many patients still will have continuing hormonal syndrome that requires further intervention. For those patients with progressive disease after somatostatin analogs, we have several options, but inevitably there is still progressive disease. So while we have targeted therapy that's FDA approved in the form of everolimus for pancreatic and GI tract and pulmonary neuroendocrine tumors, and in pancreatic neuroendocrine tumors, we also have sunitinib. There are a number of other tyrosine kinase inhibitors that are in clinical trials and are starting to report out results now, such as cabozantinib and lenvatinib, and most recently sulfatinib. But still, there will be the increasing need for other targeted therapies. And while we also use chemotherapy agents in the form of capecitabine and temozolomide for some of these patients, there's certainly need for additional chemotherapeutic agents. And while one of the greatest impacts so far on the disease has been peptide receptor radiotherapy, such as lutetium-177 dotatate, there certainly are a number of similar radionuclides that are in development that may be useful ultimately in patients who have progressed on lutetium-177 dotatate or might be used in place of lutetium-177 dotatate. So basically, the answer is we have a number of therapies, which is gratifying, but we still have the need for substantially more and for some with newer mechanisms of action.